At Five Star Bank, community is at the heart of what we do. Every day we strive to have thoughtful solutions for our customers and help our communities prosper. Honest dialogue about the issues affecting the region is vitally important to that prosperity. We are proud to be part of the conversation and hope you'll join in.
The most common mental illness in America. Most people assume it's depression, but anxiety afflicts more Americans than any other condition. Almost 20% of the country suffers some form of anxiety. This condition can be crippling, affecting their ability to work, to go outside, and even to have meaningful relationships. Robin Kirk is a licensed therapist and founder of Sage Psychotherapy Associates. She joins us today to discuss anxiety and its treatment. Later in the show, one of her patients, Jackie Feaster, joins us to discuss her battle with obsessive compulsive disorder. Robin, what exactly is anxiety?
Anxiety is, you can think of it as a kind of a cluster of physical sensations, and it differs from fear in that, let's say you're walking on the American River Bike Trail, and anxiety would be, what if I see a rattlesnake? And fear is, there's a rattlesnake in front of you and you need to run.
And this whole question of what if, that's at the center many times of anxiety. Can you help us understand that?
Absolutely. It can go from like social anxiety, feeling uncomfortable at a party. What if people don't like me? What if I don't tell funny jokes? To fears of OCD, like what if I don't wash my hands thoroughly and I make my family sick? So it's really based in the future, very future-oriented. What if something happens?
And it comes across almost as if anxiety is like a paralysis. So?
Yeah, it often does, because if you're thinking, what if, then frequently we're problem solvers. Humans are great problem solvers, so we try to come up with lots of contingencies. And we also think that if I have anxiety, that must mean I need to do something to make it go away. So if I think, what if there's a rattlesnake on the trail, how am I going to protect myself? Maybe I'll take big sticks, and maybe the best way to protect yourself is to not go at all. So we try to solve a problem that may or may not actually need solving.
Help us understand the difference between true anxiety and the little fears that all of us have when we go about our day-to-day lives.
Well, anxiety isn't necessarily a bad thing. Anxiety,
Really?
Yeah, no, good. Anxiety can be really good. If you are in school, anxiety can make you study for an exam. If you have a meeting, it can cause you to be sure you set your alarm and get there on time. So it can be a really motivating factor for us, but it's when it gets over that kind of helpful amount that it gets
How can we tell? How can we tell whether we've kind of gone over to the other side where we really got an issue?
It depends on how it impacts your life. If you find that maybe you're avoiding things that you used to do, or you get that, paralysis is a great word that you used, if you get that sense of paralysis, then it's causing a problem.
And the reason I'm asking you the question is because I want to know, what's the difference between anxiety and just me procrastinating and making an excuse for not doing something?
Well, sometimes anxiety can look like procrastination. It can, perfectionism can be a form of anxiety. We think of it as a good thing, but it can get paralyzing if you think, I have to do something perfectly. What if I don't do this perfectly? And then things just seem momentous and we can end up being paralyzed.
So when people come to you, how do you diagnose the difference between just one of the little tremors of fear that we all feel and someone who really needs to go through a course of treatment?
I spend about an hour with people talking to them about kind of how it affects their lives, how they approach things, the thoughts that they might have that might get in the way of finishing a particular project or going out doing the social things that they want to do or dating. And we don't charge for assessments. I don't want people to ever feel that money would get in the way of finding out what the best course of treatment for them would be.
And is this something, is it common that even our health insurance pays for this type of stuff? And I'm asking the question because, some might say in the past, people might say, look, just get a grip, okay? This is not really a medical condition. And cynics sometimes say to this day that we're overanalyzing everything, and we're taking things that people just need to buck up and sort of, get themselves together, and we're creating a phobia out of it. Do you have any reaction to that?
I think people still hear that quite a bit.
Really?
Yeah, just stop doing it. Just stop washing your hands, or just leave the house. Don't check the door, just leave. And I think people suffer a lot, and if they could just stop, they certainly would. It's not fun by any stretch of the imagination. And insurance does pay for it. There's several mental health diagnoses that are considered biologically based. And so as long as there's medical necessity, insurance is supposed to pay for treatment, and OCD.
You raise a really interesting question, because increasingly over the past 20 years or so, what we've seen is what some call the medicalization of mental health treatment, where it is that if there's a condition, if you feel depressed, if you feel whatever, we'll prescribe a pill for you, and psychiatrists do that. But when do you know whether or not medicine, as opposed to therapy itself, is really the way to go?
Often people will come into our program on medicine already. On medication.
Really?
Yeah, on medication already, quite frequently.
So the physician is the first stop, and then they come to you?
Frequently. And a lot of people will be in treatment and realize that they're just not making the progress that they could, and go in for an evaluation. And usually the things that are prescribed are the antidepressants. Some of the same serotonin and dopamine seem to be involved with anxiety disorders as well, and they can be really effective.
And the most common forms of anxiety that afflict the country today, what are some of them?
There are quite a few, actually. There's generalized anxiety disorder, which is what it sounds like, just kind of a pervasive sense of anxiety all the time, not necessarily related to anything in particular. There's social anxiety, and PTSD, post-traumatic stress disorder, obsessive compulsive disorder, and then some related disorders like skin picking, hair pulling.
PTSD, that's like the soldiers that come back from war, and that's actually a fairly common form of anxiety in this country today. Is it all from wartime related things, or do other types of situations cause PTSD?
Other types of situations do. Civilians can certainly get it. It's generally either observing a disaster, or someone being harmed or close to death, or being in a dangerous situation yourself will frequently cause it.
And when someone suffers from anxiety, if they are not coming through a physician first, in the case that you referenced, how do they end up coming to see you?
Frequently they're referred by therapists. Someone might be in individual treatment, and traditional insight talk therapy, which I love, isn't always as effective as we would like with anxiety disorders. Because you can have lots of insight, but then you have to know what to do with it.
And in regular talk therapy is when we discuss things back and forth and try and work through issues. But what you do in terms of your clinic is something far different. Can you explain what that is?
Sure. We combine two different treatment modalities. The first is acceptance and commitment therapy, which really teaches people a different way to experience the physical sensations that come along with anxiety, plus get some space from their thoughts. When your thoughts start spinning, if you ever have had trouble sleeping at night, to be able to get some space from that so that you don't have to react to those. And so we spend about the first couple weeks really grounding people in that, and then we start with what's called exposure and response prevention, which is a behavioral treatment and pretty much is what it sounds like. If I had a snake phobia, I'd be exposed to maybe a
You put a snake in my face?
No. Not the first week.
Not the first week? Okay, no. All right.
And then, so you're exposed to some anxiety, because we need to trigger some anxiety so that you can practice the ACT concepts with that, and so that you can experience it differently. So we just expose people to different levels of anxiety. It's always very collaborative and very willing. We never surprise people with anything. We don't do extreme exposures. And so that you get practice feeling your anxiety, different levels, and responding differently.
How does that interact with the conversation that patients have in their head, which is that if I think of this, something else is going to happen, something else is going to happen? And what's going on when someone's having that internal conversation about whatever their anxiety is, and at the same time you're exposing them on a physical level to whatever condition it is that makes them so anxious in the first place?
One of the things that happens is that people attribute kind of extra meaning to thoughts. Like if I have what if fill in the blank thought, that must mean something. It must be important. I have to do something about it. So we help people to get some space from it, or to be able to see a thought as just a thought. I'm just having a thought that this might be the case. Is that something that is helpful for me? Do I really need to do something about it? So get some space from them.
And people having thoughts and these internal conversations in their head, is it merely just replacing that sort of negative loop with a positive one? I mean, there's a lot of self-help type of thinking and that's out in the popular culture, which is you just take your bad thoughts and replace them with good thoughts. Is it really as simple as that?
No, it's not. The acceptance and commitment therapy, that acceptance piece, that being able to just let a thought come and go. You don't have to struggle against it. I don't know about you, but if I try to calm down, if I try to struggle against my thoughts, replace sad thoughts with happy thoughts, you just kind of push up against it, and it pushes back. Yeah, it gets stronger often, which is unpleasant and kind of counterintuitive. It's what we try to do, just replace them with positive affirmations. But then our brains kind of argue back, and we end up having an argument with ourselves, which isn't great.
So it sounds almost like you're teaching people to be in the moment with whatever that worry is, and to walk alongside of it, more or less.
Absolutely. Yeah, absolutely. We teach mindfulness meditation as a part of the program, and people practice regularly, and that's being in the moment on purpose and without judgment, without trying to push things away or get more of something, just really being present in what happens in this moment. Because if you're really present, you're not having those what if in the future thoughts.
Now, how often do people make it to the end of their treatment plans? Or I assume that there's a lot of dropouts along the way.
There frequently is, and that's one of the issues in the psychological community that we talk about, is that exposure can be effective for people, but it also has a high dropout rate. Like 25 to 30% of the people who start it drop out early, because it is difficult.
Have you ever had a case where when you went into it, obviously as a therapist, you're hopeful for all of your patients, but you thought, man, this one's going to be tough, and they actually made it to the end?
Oh, sure.
Share with us.
Oh, absolutely. Oh, boy, several. I mean, it's somewhere the person is has so much shame around their what if thoughts that they're socially taboo, which happens a lot in OCD, that they have a hard time even describing to you.
Now, you're thinking of a patient when you're saying this. Tell us about that individual.
Well, there have been a couple of people. One man a few years ago he was afraid, his thought was, what if I'm a pedophile? And what's really important to understand about OCD is it's not that they want to be. The fear is, what if I am? They're absolutely terrified that they might be. So a thought just goes through their head, and it has extra meaning. So he also had young daughters. And for 2 years, he saw his daughters very rarely, because whenever they were home, he would lock himself in his bedroom. So he was so terrified that those people, that he might harm his daughters in some way.
Is that difficult for you as a therapist when someone presents a socially abhorrent type of condition such as that, in terms of what their concern about themselves is, and about the fear that they might have toward harming someone?
Not at all. No, because with with OCD, the what if thought could be anything. It could be, what if I say something stupid and people don't like me? What if I'm a pedophile? What if I'm a mom and I drown my baby? What if I don't clean the counters well enough?
But
It
but
doesn't
I'm
matter.
asking from sort of a public safety standpoint. That doesn't concern you necessarily?
No, because we have a good idea by the time that people start that it's OCD and it's a fear of something, not a desire for something. And that's really different.
Okay. Thank you for sharing that distinction. We'll come back in just a moment. You're watching Studio Sacramento, and when we come back, one of Robin's patients joins us.
What if news wasn't just a commodity,
but a commitment?
The fiscal cliff is a fiscal suicide.
Why shouldn't we explore every side of the story?
The Syrian army had pulled back.
Where can you turn for news you can trust?
How do we make sense of something like this?
On PBS, we believe journalism should never stop asking questions.
Give to your PBS station and support independent journalism.
We answer to no one but you.
Thanks for staying tuned. Let's get back to the conversation with Robin and one of her patients, Jackie. Welcome to the show.
Hello.
So, what is the condition that you've been laboring under?
Well, for me, OCD, some of my obsessions as far as thoughts would have to do with contamination, especially in the kitchen and the bathroom. I also...
Give us an example of what type of contamination you're talking about.
I worry, when cooking something, I worry about it not being thoroughly cooked, so that's one of the reasons why I don't deal with meat. I don't like meat being in the kitchen. I start feeling that there's germs and stuff like salmonella for chicken and stuff that'll be spread around, so I have to make sure all the countertops are cleaned and stuff like that. I also have an obsession with the thoughts of feeling dirty. I don't like dirt on my hands necessarily, although I've kind of combated that issue. My feet are a big thing. I used to never wear flip-flops and, open-toed shoes without having to wash my feet constantly. Like I'd go in a public bathroom and wash my feet in the sink.
How did it affect your day-to-day living in terms of what things did your condition keep you from doing?
It kept me from doing a lot of things. As far as contamination goes, I used to work hands-on with people, literally hands-on face and stuff, and I would I would just get anxiety about touching somebody's face, and what if I give them a bacteria infection, or if they give me, what if there's a cut on my finger that I don't notice? So that had to do a lot with why I'm not working right now. And then also with social anxiety as well. I get a lot of judgment. I feel that there's a lot of judgment going around about me.
Really? So it's affected your relationships as well?
Absolutely. There was a point in my life where I was not leaving my house.
Wow. What was the worst point in your journey through this condition that you've had?
I think that's where I hit rock bottom, was when I wouldn't want to leave my house. I'd have a fear that I'd go into a social situation, I wouldn't be able to escape it. There would be no way for me to get out of it. I ended up no longer working because of that. So I think that was really my rock bottom. I was afraid to drive for a long time. I refused to drive at night, so it was really hard for me to have somebody drive me places.
How did you do the normal things of life, like, for instance, getting food from a grocery store or paying your bills and stuff like that when you were at that point?
Some bills went unpaid.
Okay.
So, that definitely had an issue on that. They would eventually get paid, just maybe not on the date that they were due. As far as grocery shopping, it's always a nightmare still this day. I can't stand going grocery shopping.
Really?
Yeah, but I make sure that my husband's with me.
Mm-hmm.
So there has been times where I've had to just stop at an aisle and literally put my head down on the cart and kind of take some breathing moments to breathe, especially when an aisle is really busy, people are around with shopping carts and hitting you, and so I get I have a bubble around me.
Right. And for him, for your husband, what would you say has been the toughest thing for him?
Seeing me go through it.
Yeah.
And not knowing how to deal with it.
Not knowing how to help. I have a question on that. Well, how do family members and loved ones help? Where do they go to get some information?
Well, for the people in our intensive program, we have a family support group that's for the family members or really close friends, and we meet weekly. So they really do need education about anxiety disorders and how to help, because a lot of the intuitive ways of helping actually are counterproductive.
Like what?
Like checking for someone to make sure the door is locked, or giving them reassurance that everything's okay, or that you didn't do something bad, or that letting them know that they didn't get sick after eating something.
That's actually counterproductive.
It is, actually.
Really? Why?
Well, the person gets a little bit of anxiety reduction from that, but then it feeds into the idea that if I have anxiety, I need to do something to make the anxiety stop, as opposed to, okay, I'm feeling anxiety, I can let it dissipate on its own.
Now, explain to us the distinction between obsessions and compulsions.
So an obsession is, those are the what if thoughts that we were talking about earlier. What if I get something on my hands and I make my loved one sick? Then the obsessions are, it's pretty much anything you do to make yourself feel better. So it can either be an approaching behavior like washing your hands, or it can be avoidance, not touching doorknobs, letting somebody else open the doors for you. And there can also be thought compulsions, and those are kind of the positive reinforcement things, the happy talk things, or reviewing, like in a social situation, well, what did I say? How did they react? What was their facial expression? So it can be pretty much anything you do to make yourself feel better.
Right. So Jackie, when you were first afflicted with this condition, how did you know that you needed help?
When it got so bad that I was losing myself.
Losing yourself?
There were a lot of things that I no longer did. I used to be a very social person, and I'm getting a little bit better. But I mean, I just stopped. I am very artistic, and it got so bad that there was a point where I just didn't pick up a paintbrush or scissors to do a collage or anything.
No energy, or just?
Didn't have the energy. I mean, my thoughts and my compulsions basically consume my life.
And one thing about OCD and anxiety disorders is depression is often secondary to that. So people will not only have an anxiety disorder, but life gets so much smaller and your relationships are affected. So depression is really common with it as well.
And when a lot of times when people are depressed, they become paralyzed. They can't really take action. How did you take the action to get yourself into treatment?
Well, I just finally realized how it was affecting my relationships, and I went to a psychiatrist and started out with medications. And I also realized that it can't just be medication-based. There has to be a therapeutic way as well. So that's when I started doing one-on-one therapy with my therapist. And after working with that, you know, it did help to bring insight to what was going on in my life, but it wasn't really helping me at home necessarily. So she actually brought Sage's IOP to the table and, you know, left it up to me gave me a brochure and left it up to me to make my decision. And I thought about it for a really long time.
Well, I'm asking the question because one of the things that people at home really want to know from listening to you is if we've got a loved one who has an affliction of whatever sort, dealing with anxiety, how do we, as a family member or friend that wants to help, what advice can you give us as to how we could best help?
I think be supportive of the situation and leave it up to that person to choose whether or not they want to go into an outpatient program, inpatient, whatever it is that they do. It has to be that person's choice, otherwise it's not going to work. They can't be forced into it.
Okay. And Robin, what would you say as well in terms of where do we go to get help if we're trying to help out a family member or ourselves? Where do we start?
Well, People are always welcome to come in, and as I said, I do assessments for free and just give information as well, and we do some public panel discussions about treatment for the public at SAGE so that people can come in and ask questions. But additionally, just knowing it's often an average of 7 years before people get help, which is a long time to suffer.
It is, but in your case, you have gotten help and you've made some strides. As a matter of fact, you went to Burning Man.
I did.
Yeah.
And I didn't get to shower much either.
Now, don't you roll around in the mud and dirt and things like that at something like Burning Man?
Well, when you first get there and it's your first time being there, you're considered a virgin.
Mm-hmm. A virgin.
A virgin. So what they do to the virgins is they have you, once you get into the front of the line, they have you get out of your car and roll around in the dirt because you need to get the playa on you because it's just going to be on you anyway by the next day, you know? So why not get a roll on it? Exposure right there. So yeah, I was able to actually do that. And the whole drive to Burning Man, I was just like, oh, am I going to be able to do this? I had anxiety, you know, what if I feel so uncomfortable? It's a long drive back. I can't just leave. This is a lot of money. So I had a lot of anxiety to that. And I got there and I just thought exposures in my head, I can do this. This is my homework. I've been boot camping it for, you know, a long time.
And you made it work.
I did. In fact, my friend was just like, you just went down like there was no problem.
Well, that is fantastic, and we're going to leave it there. Thank you both for coming on. And that's our show. Thanks to our guests, and thanks to you for watching Studio Sacramento. I'm Scott Syfax. See you next time right here on KVIE.
At Five Star Bank, community is at the heart of what we do. Every day we strive to have thoughtful solutions for our customers and help our communities prosper. Honest dialogue about the issues affecting the region is vitally important to that prosperity. We are proud to be part of the conversation and hope you'll join in.
All episodes of Studio Sacramento, along with other KVIE programs, are available to watch online at kvie.org/video.